Evidence for that we will be discussing in this presentation. Okay, so interventions could be basic from this lumbar epidurals to medial branch block, or it could be RFAs, or it could be this neurolysis procedures, or it could be a spinal surgery, which could be endoscopy or anything. It is just all the spinal procedures. I'm just discussing about that thing. So first of all, the problems which are faced during the early post-op rehabilitation period. So immediately the patient, when he or she is out from the OT and he's been kept in post-op ward or area. So the basic problem which is being faced in early 2 to 3 days is basically the avoidance of functionality or fear of movement. Kinesophobia is one of the most important thing that is there. So patient thinks that the any movement or the previous the phobia of the movement was there, so he or she thinks that the pain could exacerbate or the pathology could worsen. So these things should be are in patient mind that we have to address. Joint and muscle stiffness are always there, especially at the site of insertion of needle or there. For example, for lumbar procedure, the erector spinae muscle spasm is always there. Acute pain exacerbation is always there. Chances of that are there due to needle injury. Due to that, when we insert our needle, then it causes iatrogenic injury to the muscles and soft tissue, even ligament area. So there is a muscle trauma, nerve injury, which can cause acute pain exacerbation. That has to be managed very well post-operative period. Soft tissue and muscle edema are always there. Even some hematoma can also be formed. Always it is small amount is always found whether you use whatever gauge needle you use. Wearing out of effect of local anesthetics. So during the intervention, you give local anesthetics, which could be Zylocard, lignocaine, or bupivacaine, whatever you give. So as the effect of this local anesthetic wears out, the patient starts getting the pain. So at that point, the patient becomes anxious and he feels that the procedure has been done right or not. He started overthinking. So at that time, so these are the problems which we see. One important factor is the perioperative or preoperative pain. If the patient is already having a lot amount of pain before the intervention, then he expects some post-operative pain also. So it has been shown in many studies that perioperative or intraoperative pain, preoperative pain predicts the future post-operative pain also. So what are the red flags which we see, which we should keep in mind post-op? So if in the next 6 to 12 hours or 2 to 3 days maximum, so if the patient is having worsening of pain, if the patient is complains of little muscle soreness, little pain over the injection site or intervention site, then you can ask the patient to apply ice packs 4 to 5 times a day, 10 minutes each, and take little bit of rest. Then it usually goes away, the needle pain and all those pains. But the patient is having worsening pain and is having a persistent severe pain, that is NRS 7 to 10 grade, 7 to 10 if we score. If the patient has persistent pain, then something is wrong. So we should be investigating that thing. What is the reason for that? So if the patient is having signs of infection like fever, chills, or increasing swelling or redness over that area, pus site at that site, so there could be signs of inflammation. The patient having fever, and if fever, then we have to go for CBC count. The patient have increased TLC count, increased ESR, CRP parameters, then it is suggestive of infection. So infection usually manifests in post-intervention around 1 to 2 days. Around 1 to 2 days, the patient has increased pain and fever and all these symptoms. Signs of hematoma: if you are using thicker gauge needles, or you are manipulating too much in the spine, or you are not, you are damaging some venous area or arterial area, then there could be a sign. Or patient was on antiplatelets or anticoagulants, which you missed or patient didn't tell, or sometimes patient are taking some herbal medicines which they don't tell. Okay, and that time the bleeding could be there. So it could lead to the swelling, redness over that area. The patient could have leg pain or fast progressing neurological deficit due to hematoma compressing the nerve roots. Signs of nerve damage could be there. When you inject, you could be damaging the DRG or the nerve root, or any other structure you could damage. So the patient would have pain, post-operative, numbness, tingling, muscle weakness, loss of bowel bladder control. So these are the things which you should remember. So after every intervention, after around half an hour after intervention, I always ask the patient to move his ankle to check whether he, or I check the sensation also that there is no nerve injury is there. If there is nerve injury, then we should immediately do some re-exploration what exactly has happened. So factors affecting recovery rate post-procedure, there are multiple factors which we should keep in mind. If the patient is obese, then the time will be much more, rehabilitation will take much more in those cases because there is increased joint loading over the spine. Osteoporosis is there, it negatively affects the recovery rate. If the patient is having chronic illness like diabetes and any metabolic disorders, they have little slower healing of the tissues, so the patient will have longer post-operative period. Malnutrition is there, then it is also negatively affects. If the patient is having psychological issues like stress and too much anxious about the procedure, you are getting repeatedly calls from the procedure patient that I am getting this, I should do this, I should not do not that. Always in such a patient add an anxiety. If you receive 3 to 4 calls post-operative from any patient, single patient, understood that he or she is anxious, whether he should accept, you should add an anxiety, low dose anxiety. If the patient having a history of prolonged opioid use, then the medicines which we are giving in post-operative period may not be sufficient. So we have to add a little bit more dose of weak opioids more. He or she was in prednisolone or any steroids, then the recovery rate is a little bit slower. The patient had used some smoking or nicotine products, then the healing rate is slower. What happens, some patient thinks that immediately post-operative they will get better and they will start running and all those things. Some have very high expectation and they just don't take medicine. They label every medicine which we are giving, that is NSAIDs, any anticonvulsant, whatever medicine we are giving, they label them, they are pain medicine. So patient, doctor, I am having good relief with your intervention, I am not having much pain, shouldn't I skip those pain medications? But ideally you should not. So at least these pain medications, NSAIDs, and all this medication plan which you are going on, they should be controlled at least 5 to 7 days, at least post-operatively. Failure to care for the incision site, for example, if the massage, doing some massage or applying some multiple creams or something like that over the, especially in cases of spine surgery or endoscopic surgery, these are, or vertebroplasty if you are doing, so they can lead to local infection at that site. Sedentary lifestyle is there. The patient is immediately after surgery, he is going to office and sitting for 12 hours. So then you can't expect much relief in that patient. So these are the things. So goals of rehabilitation post-intervention, our main goal is that first of all, you have to reduce the pain. Post-operative pain should be less as possible. The patient should feel better than before, and he should have gradually increase the physical functioning so that the patient have a good life, shorten the recovery time and improve the quality of life. So team approach, if we see, the rehabilitation involves always a team approach. A pain physician or physiatrist can only guide what things have to be done, what not to be done. A decision making or team approach can be followed. But there is a role of counselors who will counsel that the very small questions, should I do this, should I do that? These are the questions which needs to be answered by counselors. And physical therapist will help in exercises and use of physical modalities if needed. Occupational therapist will help in advising the postural care, how to do get back to their normal regular jobs. Rehab nurse and use of psychologist in case of any stress areas. Phases of rehabilitation, initial phase from 0 to 2 weeks. The first and most important factor is patient education and counseling. Immediately after the intervention, the doctor should at least spend 10 to 15 minutes explaining what he or she doctor has done to the patient, what we have achieved, what problems which we faced during the intervention. Because these are the important things, that that your case was a difficult case and I did a lot to make you all right. So these are the things which need to think. Along with that, what you need to do in the post-operative bit, how you should lie. Already you should make a complete checklist that these are the points which we need to explain to the patient relatives, because what will happen, you will go to, after 1 to 2 hours, you will receive call from the patient that this problem, what should I do, what should I not do. So all things need to be explained beforehand. In initial year 2 weeks, rest period depends upon what intervention are you doing. If you are doing some lumbar epidurals or middle branch block, then 1 day rest is sufficient, and you can join the activity. You can join the your normal life from the 2nd day onwards. But if you are doing some bigger procedure like vertebroplasty or this endoscopy discectomy, then 4 to 5 days rest is up. It depends upon patient to patient. Avoidance of pain exacerbating activities like forward bending, backward bending, and all those things need to be explained to the patient. Medications like NSAIDs, short course of muscle relaxants, weak opioids like tramadol, trabentadol, anticonvulsants, according to the symptomatology has to be given, and then if the patient have good relief, then it needs to be titrated down after 7 to 10 days. Gradually increase the activity. Walking can be promoted. If the patient is okay, then we can ask him to walk as much as he tolerates it. Physical therapy, therapeutic exercise, as we discussed, that the stretching followed by strengthening exercise need to be emphasized. Aerobic activities in this early phase, walking is being advised. In intermediate phase, that is after around 10-15 days has elapsed, usually the effect of intervention starts. So the patient already gets relief, and at this point of the program, we need to change the exercises or make the exercise from isometrics. We can have to go for concentric, or we have more rigorous exercises we need to do. Home exercise program needs to be told to the patient that you have to do by your own, and gradually it has to be increased. Repetition has to be increased. Functional training, if the patient is experiencing specific limitations in activities of daily living, then we have to identify that and correct it. Aerobic exercises like walking, swimming, and cycling can be gradually emphasized in these patients. Reduction of pain medicine after 5 to 10, when the patient has got good relief, started gradually titrating down the pain medicine we should do. Pain management strategies like relaxation exercises, mindfulness, CBT, which I have discussed yesterday, needs to be emphasized in this patient. These will help in long-term pain relief in these patients. Return to work. Advanced phase, if we see beyond 6 weeks, long-term home exercise program and maintenance program has to be given to the patient. Maintain correct posture while doing activities. Lifestyle changes like weight management, reduce sitting. The sitting should be not more than half an hour continuously. He or she should get up from sitting position after every hour. And positive outlook to life. Those patients who have positive outlook to life, they perform better. They have fewer recurrences of pain. So that has to be emphasized in your when you declare that the patient is all right and you are all right from my side, and you have to follow the home exercise program and these lifestyle changes. So if I was looking for the evidence and for spinal interventions, most of the things which most of the articles or some RCTs or meta-analysis which I found was for the lumbar spine surgeries, but for the interventions, specifically the epidurals and middle branch and all this minimally measured, that there were no specific articles which are comparing the physiotherapy or rehabilitation which needs to be done immediately after that. So I could not find much articles. So there was one article published in Archives of Functional Medicine Rehab, in which they compared two groups. One is the epidural steroid injection, and another group was this epidural steroid injection plus physiotherapy. So it was found that if we see the disability, so there was no significant difference between the two groups. Epidural steroid injection plus physiotherapy was not superior to epidural steroid injection alone for reducing disability in individuals with lumbar canal stenosis patients. But if we see, if we add physiotherapy to ESI, then significant benefit was found in quality of life factors like emotional function, general well-being, and general health. So their RCT was there for effectiveness of physical therapy and epidural steroidizations in lumbar spinal stenosis. There are two groups. One is physical therapy and epidural steroidization in lumbar spinal stenosis, and both it was found that both at the 6 months of follow-up, both were found to be equally effective. So that does no comparison between post rehab in this thing. There was a meta-analysis systemic review, was effect of early rehabilitation after lumbar spine injury. So it showed that early rehabilitation mainly improved disability if we see in 1 month follow-up period, better pain control in short term as well as mid term. But there's insufficient evidence of effectiveness of early rehabilitation in terms of quality of life and psychosocial status. And if one of the article which I found was from Cochrane database, systemic reviews, rehabilitation after lumbar disc surgery. It showed that exercise programs starting 4 to 6 weeks post lumbar spine surgery seems to have faster decrease in pain and disability than no treatment. High intensity exercise program led to faster decrease in pain and disability than low intensity programs. No significant differences between the supervised and home exercise program. So if you are after 4 to 6 weeks of post surgery, if you are giving home exercise program, that is same effect if you are calling for the patient for the do exercise under supervision. No evidence that the active programs increase the reoperation rate. So people think that after doing exercises, this is a common misconception that I have got my lumbar spine surgery done and don't have to do any exercise for next 6 months or throughout my life. So it showed that the active programs, there is no evidence that the active programs increase the reoperation rate. So this is the thank you.